everyone, and welcome to Youth Positively Speaking's show, Action to Avoid Opioid Addiction. My name is Paige Ewing, and I work at Prevention Resources as the multimedia specialist for Positive Youth. Prevention Resources is a nonprofit located in New Jersey that is dedicated to promoting health and wellness of individuals, families, and community through education, collaboration, advocacy, and treatment. Today, my co-host is Erin Cohen, the project coordinator of Positive Youth Initiative and the Prevention Resources Prevention Director.
Thanks, Paige. Again, I'm Erin Cohen, and the Positive Youth Initiatives focuses on building countywide capacity to reduce substance misuse for youth 9 to 20 here in Hunterdon County.
So we are very excited to be hosting this show on our platform to really help educate and inform the public about the opioid epidemic, alternatives to opioids, and educate the public on a bill called the NOPAIN Act. And we're working with Voices for Non-Opioid Choices to educate and advocate for healthy communities through these non-opioid choices. And so today we have with us Dr. Joseph Smith. He's an anesthesiology specialist with over 28 years of experience in the medical field. And so Dr. Smith, welcome to the podcast. We are very excited to have you today.
Thank you so much for inviting me.
So could you tell us a little bit about what is an anesthesiology specialist? What do you do?
Absolutely. Well, again, you know, I'm quite involved in the fight against opioid abuse. So it's a real pleasure to be here. An anesthesiologist, I think most of your listeners will know, is the person that puts you to sleep so that you can have surgery and not have pain post-op or, during the surgery. So we're the ones you meet right before surgery. And we talk to you about what type of anesthesia you're going to have and have you drift off to sleep and so that you have a comfortable and you don't feel any pain during surgery. So that's what anesthesia does. Now, there are other aspects to anesthesiology, like being a anesthesiology pain doctor, where you actually go into an office, and we're an office doctor, and we sit down and we talk to you about your pain, and we can do specific blocks. But for the most part, when you think about an anesthesiologist, they're in the hospital and they're putting you to sleep for surgery.
Mm-hmm. So could you tell us a little bit more about, for anesthesia, like what is your role in patient pain management?
Yeah, so I think we can tailor it to this conversation. If for any type of surgery, you're going to be there are different options to going to sleep. So if you're coming in for appendicitis, so let's say you're a 10-year-old and you happen to have appendicitis, well, you're going to have an IV started and you're going to drift off to sleep and have a little breathing device after you're asleep, and they're going to do the surgery, and we're going to most likely have to give you narcotics to control pain for the surgery, right? But there are other types of surgery where you have choices of how to control pain, and sometimes you can avoid narcotics completely. And I think even there are some people across the country that advocate that you don't even need narcotics for any kind of surgery. But specifically, let's say you're coming in for a shoulder surgery and you have a torn rotator cuff, which is a type of injury that's very common, and you get a surgery for that. Well, I often do those procedures. I do a lot of orthopedics and pediatrics and all sorts of anesthesia. But for that type of surgery, I can do what's called a peripheral nerve block, where I take a look at your neck with an ultrasound machine and I find the nerves that go down and innervate your shoulder. And I numb up the skin and I go in and I bathe those nerves with local anesthetic. And that makes your shoulder numb. And it stays numb, depending on the type of medicine that I use, for up to 3 days or 4 days. And so that is where we get into the ability to avoid narcotics completely, which is something that I'm very passionate about, and something that the public really needs to understand is a possibility, and they need to be educated in that process.
That's a really good point that you said, that it can last 3 to 4 days, because oftentimes after people have surgery, then they are given opioids directly after surgery for several days, correct?
Yeah. So, when you're trained as a physician, I was, when I was, you were always writing for 60 Percocets or something like that to give them,
Right.
here you go, just take these, until you don't need them anymore. And the problem is when I was, I live in Virginia, as you said, and I practice, and we were very close to West Virginia, which of course, everyone is devastated by the opioid epidemic, but in West Virginia in particular. And I was, I was looking at this saying, this is horrendous, this is incredible, who's responsible for this kind of thing. And, I realized that I was one of those people that were responsible because, when you have surgery and you come in, it's about 10% of the patients that have procedures in the hospital and go home on these narcotics, 6 months later or a year later are addicted to the narcotics.
Mhm.
So, we as physicians, surgeons, and anesthesiologists are to blame for part of this. And so I think it's, and if you talk to so many people who are involved in the opioid addiction process, and it's amazing how many people take this route. They've had surgery, they went home, they took narcotics for post-surgery, and they were never able to get off of them.
Mhm.
And especially young kids, the 17-year-old takes it and it's like their brain, oh my God, my brain has never felt so good in my life. So
Mhm.
they finish those narcotics and then they try to, buy some at school, and then they go to the much cheaper and much more variable heroin on the street. So,
Right.
there has to be a way of intervening at that vital place where kids are having surgery, teenagers are having surgery, and preventing them from ever taking a narcotic, even during the procedure, because I don't know what changes in the brain are happening even when they're asleep. But
Mhm.
most importantly, that they don't go home and take these.
Right.
Mhm.
So I think you make a good point about how everybody's different. We don't know what it is that lights up one person's brain versus another who can take it for 3 days and be done and never take it again. What do you recommend for patients to advocate? What do you recommend them to when they go into the doctor and they're having surgery? Because most people don't really, I feel like, ask these questions. What do you recommend?
Yeah. So if I think for parents of teenagers and kids that are going in, or anyone for that matter, but this is something that's near and dear to my heart, is trying to prevent the kids from getting started on this stuff. And to go in and say, I'm interested in a non-narcotic technique, to say, listen, is there any way that we can do this surgery without my kids ever having to receive narcotics?
Mhm.
And some surgeons will say, as a matter of fact, we can, and so that you are doing a type of nerve block that lasts for a long time, and you're taking what's called a multimodal approach. A multimodal approach is when you're taking a lot of different non-narcotic medications that work at different aspects of the pain, different areas of the brain, different areas of the body. So, you're thinking of things like Celebrex, which is like a high-powered ibuprofen, and
Mhm.
Tylenol, and all these other drugs that, sort of contribute. The drug that I use and there's many of them, the drug that I like to use is something called Exparel. And Exparel is something that I mix in with the medicine that I inject in the peripheral nerve block. And that is the thing that helps it's a special type of medication that slowly releases the local anesthetic over 3 days. And
Mhm.
that's what allows these patients to avoid narcotics. And it's really been an eye opener for me. I started doing this, wow, 6 or 7 years ago or something, even more. I can't even remember now. I should probably have that. Um, but so, and it was amazing because before the long lasting drugs like Exparel, we would use just a local anesthetic called bupivacaine. And that would last 24 hours, which was great because you could get them through the surgery without giving them narcotics, and then you could get them home. But the problem is that at 24 hours, it was like turning off a switch. They'd be like, hey, this is great. And then I'm in excruciating pain.
Right.
And so they would invariably need to take narcotics to decrease that pain. With the long-lasting medication, then it would sort of more gradually wear off, and it would last a lot longer. So they were able to avoid having to take the narcotics, and it was wonderful to see. You know, you would call these people, and they would be like, "Yeah, I haven't had to take any, narcotics and all this kind of stuff." And a really great, side, something that was wonderful in addition to not having to take narcotics is that we were able to decrease or eliminate the pills that we send home. Because if you go home with 80 pills or 60 pills or 40 pills and you don't take them and they're sitting in your cabinet, guess what happens? The 14-year-old gets a hold of them, tries them, or takes them to school and sells them.
Right.
So there's a lot of that with these medications. So not only are we decreasing the chances of these patients becoming addicted to these substances, but we're decreasing the supply in the community, which was wonderful. In addition to really encouraging them to bring back those narcotics to us so that we can dispose of them. I think that doesn't always happen. So I think it's really important to decrease the number of pills that are available to be misused by family or friends.
I'm so glad that you bring up, helping communities by reducing opioids in the communities from our medicine cabinets. And I think that's why we really advocate for people to use the medicine disposal drop boxes in their community. I know here in Hunterdon and Somerset County, there's one at almost every police station. We were talking with ShopRite. They want to get one because they have a pharmacy there, really making sure that our community members know how to dispose of them, by either going to the drop box or even, knowing that they can take the medication, put it in a Ziploc baggie with some kitty litter, coffee grounds, something like that, pouring the medication into the bag, shaking it up and tossing it away so that it becomes unattractive to somebody who might want to go through the trash to find those opioid medications. And I think, by having providers like you who are not only advocating for patients to have alternatives, but then also for community organizations to say, okay, if you do have an opioid, because there are absolutely necessary times that somebody's going to be prescribed them, but it's like when you get them, use them for the prescribed amount of time and then get rid of the rest so that nobody else is at risk for an opioid use disorder.
I agree 100%.
And the other thing too, so Dr. Smith, now that you have, you're very passionate about this and you've seen that there are other things that you can do opposed to using opioids, tell us a little bit about barriers of insurance, because we hear this all the time that providers have barriers, patients have barriers. So tell us a little bit what you deal with.
Yeah, I think that's an important topic, and I'm in a unique position because not only do I work in a surgery center, an outpatient surgery center, but I also work in the hospital that's next door to that surgery center.
Okay.
So there's two different things going on. So the CMS made it so that they would pay for some of these non-narcotic alternatives in the surgery center. So before they did this, if you go to have surgery in a surgery center, it's something, we do something called bundling payments. So that means that the surgery and the anesthesia and the payments for all the medications are all bundled into one payment, right? So then you have someone who, you have a surgery center administrator looking at this and saying, well, do I really, if I'm only get paid this one amount, do I want to really pay for this really expensive, or expensive drug that would decrease narcotic use? So the Exparel that I use for the surgery would probably be about $150 extra for a surgery. So there are a lot of surgery centers across the country that said, no, I'm not going to pay that extra amount. You know, we can get them out the door with the regular bupivacaine, and that's sort of not our problem. All right.
Mhm.
Luckily, for a lot of the CMS said, okay, we're gonna unbundle those medications for the surgery center. So therefore, we can use those medications, and most of the insurances will pay for us to use that medication, so that the surgery center gets reimbursed when they use it. Unfortunately, CMS did not see their way to make it available in the outpatient surgery department of the hospital. So when I go and do a surgery, I work in the main hospital as well. So I'm doing the same kind of case, the same kind of shoulder surgery in the hospital. The pharmacy won't give me that medicine. I say, well, listen, this is going to be great. It's a 17-year-old. He shouldn't be exposed to narcotics. Please give me that $150 medicine, and we could maybe prevent, what's wonderful for society, which is decreasing,
Right.
this. And the pharmacy's like, nope, that costs too much money. I'm not going to give it to you. Sorry. And it's so frustrating because these people really deserve it, especially the really elderly people. The last thing they need is to be, taking narcotics at home. They're already, have some trouble breathing, and and so we're diminishing their ability to breathe and all this kind of stuff. And so they deserve to have this medicine as well. So those are the kind of roadblocks that I run into. And you did mention the NOPAIN Act. So the NOPAIN Act would remedy that. That law would allow for these kinds of alternatives to narcotics to be unbundled and be paid for by insurance. So I think that's really important. That I'm a big advocate of that law, and so I think that would help a lot.
And I think that's why the No Pain Act is so important, because it really isn't taking any tools out of the toolbox. I know that we've said this in previous episodes on this show, but really this act is just giving providers more options, patients more options, hospitals, outpatient surgery centers, everybody more options to take care of their patients, which at the end of the day, I think everybody can agree we want healthier, safer communities. And so I think that's why it's so important that, our communities stay up to date with what our legislators are talking about, because at the end of the day, when we do need a surgery, whether it's because we're an athlete, we're getting older, or there's an accident, we want to have all of the options available to us, and to, of course, our loved ones as well.
And Dr. Smith, having teenagers myself who also play sports, I appreciate that there's providers out there like you who are looking out for the greater good. And I think as time goes on, especially as this opioid epidemic continues on, I mean, we just got those numbers recently that there were over 100,000 people who died of overdoses last year. When we look at a community, in our side in prevention, the folks with the No Pain Act, with providers like you who are looking at the different options, we have to come together as a community in order to break this cycle of addiction. And if we don't have to give a 17-year-old who has an injury any opioids, that is our best bet to know that we're going to have this drug-free community later on. So as a parent of teenagers and athletes, I appreciate that.
The other thing that I've noticed, and I don't have any studies to back this up, but as I've been doing this for many years, I think it's just good medicine too. I think the patients that I don't give narcotics to, and this includes having, we do total joints in the outpatient department and things, and they just seem to do better. And I don't know what the reason. Maybe they can breathe better because they're not on the narcotics, and they don't get the atelectasis in the lungs and all that kind of stuff. But it just seems better medicine to me, for these patients.
And I would have to agree with you too. So my mom works at an outpatient surgery center. She's a nurse manager there. And for a while, they were giving IV Tylenol to their patients during surgery instead of the typical few days of Percocet. And she also saw that her patients had less pain overall. And then a day or two later, they were like, oh, I'm feeling a little uncomfortable. And they were like, oh, just, take a Tylenol or an Advil. And they were fine. And they never even needed to touch the Percocet. And my dad also works in a hospital. He's a nurse anesthetist. And I was talking to him before this podcast because I was like, okay, anesthesia a little bit, Dad. Tell me about it. And he was saying the same thing for the patients who, seem to not use the opioids to treat their pain and instead, nerve blocks or other things, they do seem to have longer, better outcomes. So I would love to see a study done to help, really reinforce that so that we can go to our insurance companies and say, look, people are healthier, meaning that they're going to need you less, meaning you get to spend less money. Because ultimately, right, at the end of the day, it's the finances that these insurance companies are worried about. Right. Which is frustrating, but at the same time, if we can prove that, these alternatives really are more beneficial in the long run, which of course we have anecdotal and some studies that prove that, it'll be even more evidence to convince them to not limit these alternatives.
Yeah, I agree. And, we're up against the finances, as you mentioned. When I was talking about the pharmacy at the hospital, we're talking about, $150 for that one dose of that medicine versus literally pennies for the narcotics, so that's the type of, that's what we're dealing with. And so it's difficult to fight that battle. And it's also difficult to fight just years of practice. My specialty, is unwilling to come quickly over to the fact that no narcotics is better than, they're just difficult to, they're dinosaurs. A lot of them are just like, what do you mean? We're still going to use narcotics. It's just as good. And, that kind of thing. But I think it's very clear that using narcotics, especially using them post-surgically, it leads to addiction and leads to a worse outcome medically.
It absolutely does. And that's something we talk about when we talk about stigma and things like that, that so many people look at folks who overdose with, they look down on them, that it's a moral failing. And so many are people that have come into your office or any other doctor's office, had a surgery, became addicted, couldn't get pills anymore, and then they turn to heroin and then ultimately die of an overdose. They're everyday people who are going in for surgeries for whatever reason, and I think as time continues on, as I think more doctors will jump on the boat with you, seeing that this is good medicine and that you can do the same thing without that risk of addiction. And the other thing too about money that I always find very interesting, when you're talking about pennies versus $150, think about what it cost our country and insurance companies for all these folks who are dealing with the ramifications of addiction to opioids. It's costing billions and billions of dollars every year, not to mention the amount of lives that are lost. The amount of money on the back end is way more than that $150 on the front end. So we have to get that mindset with everyone, and hopefully, people will continue to inform themselves and, look into, the NOPAIN Act, which really does benefit everyone in this country.
Absolutely. Yeah.
Yeah. Well, I just want to say thank you so much, Dr. Smith, for coming on, for being a fierce advocate for your patients, and then also, being an educator for other providers as well. Sometimes I think it's good to hear it from the horse's mouth, the person actually providing, to hear what your perspectives are. So I want to thank you for that. And of course, I want to thank our community members too for utilizing things like their drug disposal boxes, for talking to their providers about the alternatives, for making those steps to live a happier and healthier life. And so if you're a listener or a viewer who feels passionately about these topics we've spoken about, we do encourage you, use those drug disposal boxes, ask your prescriber for alternatives if you're experiencing pain, and then even go as far as educating your state and national legislature members about different things that you feel passionately about. For more information about the NOPAIN Act, something we mentioned a few times today, please visit nonopioidchoices.org. And for more information about opioids and our initiatives, visit our website at njprevent.com/NoPain. And we want to thank you so much for listening in, and we'll see you next time for more Youth Positively Speaking about actions to avoid opioid addiction.